Introduction. Injuries to the ACL are relatively common knee injuries among athletes. They occur most frequently in those who play sports involving pivoting, for example football, basketball, netball, soccer, European team handball, gymnastics, downhill skiing. They can range from mild, such as small tears/sprain, to severe, when the ligament is completely torn. Both contact and non-contact injuries can occur, although non-contact tears and ruptures are most common when the limb is in non-contact and combined with valgus and internal rotation trauma. It appears that females tend to have a higher incidence rate of ACL injury than males, that being between 2.4 and 9.7 times higher in female athletes competing in similar activities, and an acute rupture of ACL is a common trauma. It is incidence up to 84/100,000 persons in USA, 78/100,000th persons for Sweden, with 32 years is the mean age of injury. The ACL is a band of dense connective tissue which courses from the femur to the tibia. It is considered as a key structure in the knee joint, as it resists anterior tibial translation and rotational loads. The ACL arises from the posteromedial corner of the medial aspect of the lateral femoral condyle in the intercondylar notch and inserted anterior to the intercondyloid eminence of the tibia, blending with the anterior horn of the medial meniscus. The ACL courses anteriorly, medially, and distally across the joint as it passes from the femur to the tibia. As it does, it turns on itself in a slight outward, lateral, spiral. There are two components of the ACL, the smaller anteromedial bundle, AMB, and the larger posterolateral bundle, PLB, named according to where the bundles insert into the tibial plateau. When the knee is extended, the PLB is tight and the AMB is moderately lax. However, as the knee is flexed, the femoral attachment of the ACL assumes a more horizontal orientation, causing the AMB to tighten and the PLB to loosen, and thus leave the AMB as the restraint to anterior tibial load. That means PLB has a stabilizing effect when the knee is near to extension less than 30 degrees on rotational and anteroposterior forces, and AMB act as a stabilizer and becomes more tense with higher degrees of knee flexion. Refer to this page for more information on the ACL biomechanics. Anterior cruciate ligament, ACL, structure and biomechanical properties. Functions of ACL. 1. Primary restraints to anterior tibial displacement, counting for 85% of the resistance to anterior drawer test, when the knee is kept at 90 degrees of flexion. 2. Secondary restraints to tibial rotation and varus, valgus angulation at full knee extension. 3. Proprioceptive function, presence of mechanoreceptors in the ligaments. Mechanisms of injury. Non-contact injury. 3 major types of ACL injuries are described. 1. Direct contact, 30% of the cases. 2. Indirect contact. 3. Non-contact, 70% of the cases, by doing a wrong movement. Biomechanics of injury. As 60 to 80% of ACL injuries occur in non-contact situations, it seems likely that appropriate prevention efforts are warranted. Cutting or sidestep maneuvers are associated with dramatic increases in the varus valgus and internal rotation moments. The risk of ACL injury increase if there are more than one of these movements happened: knee joint twisted, bent backward, or side-to-side stress. When there is an anterior tibiofemoral shear force, ACL is loaded and the force is first controlled by ACL. The knee valgus moment with the anterior drawer force proximal to tibia increases ACL loading significantly, excepting to varus valgus laxity. Grades of injury. An ACL injury is classified as a grade 1, 2, or 3 sprain. Grade I sprain. 1. The fibers of the ligament are stretched, but there is no tear. 2. There is a little tenderness and swelling. 3. The knee does not feel unstable or give out during activity. 4. No increased laxity and there is a firm end feel. Grade 2 sprain. 1. The fibers of the ligament are partially torn or incomplete tear with hemorrhage. 2. There is a little tenderness and moderate swelling with some loss of function. 3. The joint may feel unstable or give out during activity. 4. Increased anterior translation, yet there is still a firm end point. 5. Painful and pain increase with Lachman's and anterior drawer stress tests. Grade 3 sprain. 1. The fibers of the ligament are completely torn, ruptured. The ligament itself is torn completely into two parts. 2. There is tenderness, but limited pain, especially when compared to the seriousness of the injury. 3. There may be a little swelling or a lot of swelling. 4. The ligament cannot control knee movements. 4. The knee feels unstable or gives out at certain times. 5. There is also rotational instability as indicated by a positive pivot shift test. 6. No end point is evident. 7. Hemarthrosis occurs within 1 to 2 hours. An ACL avulsion occurs when the ACL is torn away from either the femur or the tibia. This type of injury is more common in children than adults. The term anterior cruciate deficient knee refers to a grade 3 sprain in which there is a complete tear of the ACL. It is generally accepted that a torn ACL will not heal. Diagnostic procedures. An exact diagnosis can be made by the following procedures. Physical assessment, which includes the following tests. Lachman test. The Lachman test is a passive accessory movement test of the knee performed to identify the integrity of the anterior cruciate ligament, ACL. The test is designed to assess single and sagittal plane instability. 1. Anterior drawer test of the knee. 2. The patient lies supine on a plinth with their hips flexed 45 degrees, his/her knees flexed to 90 degrees and their feet flat on the plinth. 2. The examiner sits on the toes of the tested extremity to help stabilize it. 2. The examiner grasps the proximal lower leg, just below the tibial plateau or tibiofemoral joint line, and attempts to translate the lower leg anteriorly. 2. The test is considered positive if there is a lack of end feel or excessive anterior translation relative to the contralateral side. 3. Pivot shift. 4. The pivot shift is a dynamic but passive test of knee stability, carried out by the examiner without any activity of the patient. 4. It shows a dysregulation between rolling and gliding in the knee joint. 4. The patient lies in supine. 4. The movement is a combination of axial load and valgus force, applied by the examiner, during a knee flexion from an extended position. 4. When the test is positive, it indicates an injury of the anterior cruciate ligament. 2. MRI. MRI has the advantage of providing a clearly defined image of all the anatomic structures of the knee. A normal ACL is seen as a well-defined band of low signal intensity on sagittal image through the intercondylar notch. With an acute injury to the ACL, the continuity of the ligament fibers appears disrupted and the ligament substance is ill-defined, with a mixed signal intensity representing local edema and hemorrhage. MRI can diagnose ACL injuries with an accuracy of 95% or better. MRI will also reveal any associated meniscal tears, chondral injuries, or bone bruises. 3. Instrumented laxity testing/arthrometric evaluation of the knee. An adjunct to the clinical special tests in assessing anterior translation is the use of instrumented laxity testing. The most commonly cited arthrometer is the KT1000, Medmetric, San Diego, California. The arthrometer provides an objective measurement of the anterior translation of the tibia that supplements the Lachman test in ACL injury. It can be particularly useful in the examination of acutely injured patients in whom pain and guarding may preclude evaluation. In such patients, the Lachman and other tests can be difficult to perform accurately. 4. Dynamic ultrasonography. Ultrasound can aid the examiner in determining the presence of an ACL injury. Direct US visualization of the ACL is challenging, but US is increasingly being used as an extension of the physical examination on the sidelines, in training rooms, and in clinics.